So there are two methods of abortion care. One is a medical abortion and second is a surgical abortion. Medical abortion we have seen in detail, mifepristone plus misoprostol. All doses we have discussed last time. Then surgical abortion, in which we have manual vacuum aspiration and electrical vacuum aspiration. And third is a dilatation and evacuation. So in surgical, you have MVA, EVA, and DN. Okay, all aspects of abortion care should be delivered in respectful and sensitive manner that is person centered and recognizes women and pregnant people as the decision makers. So you have to involve the lady in making the decision. Now this particular table differentiates medical abortion from the surgical abortion. The advantages of the medical abortion is that it will mimic like a natural miscarriage. It will avoid surgery. It can happen at home, okay, depending upon the stage of the pregnancy, but it takes longer time. Okay, it may take hours to the days also. Medication may cause nausea, vomiting, diarrhea, chills, fever, etc. The chance is 1 in 10. Okay, will experience abdominal cramping and bleeding while passing the pregnancy. Okay, they will be worse, pain will be worse than their period pains, and there will be abdominal cramping and can last on and off for a week and bleeding for 2 to 3 weeks. So longer duration is there. Okay, and patient will be able to see as she is passing the products. Serious complications are not very common, and you can give all contraceptives with this, especially when the products are passed. At that time, you can give IUDs. Okay. Now, surgical abortion, it has to be in the healthcare facility. It will require expertise. Definitely will experience some discomfort during the procedure, especially if it is conducted under local anesthesia. And there will be no discomfort if it is performed under general anesthesia. The medication used to prepare the cervix cause cramps and bleeding and can cause nausea, vomiting, diarrhea, chills, etc. Will experience some pain and bleeding for 1 to 2 weeks afterwards. Will not usually see the pregnancy unless she wishes to do, because products of conception are not seen. The patient is under anesthesia. It requires pelvic examination and use of surgical instruments into the uterus. Serious complications are not very common. Okay, and all contraceptive methods, including the IUD, can be used at the time of surgical method. Okay, now health workers can help to relieve anxiety, create a safe and respectful environment, and counteract abortion-related stigma by using welcoming words when they first meet the patient, making good eye-to-eye contact, smiling in face-to-face meetings. This particular slide is not important from part 2 point of view, but it is important for part 3 point of view, especially when you are talking with the role player who has come for the miscarriage or the termination of pregnancy. So you have to introduce themselves, explain what the consultation will involve, and structuring the consultation so that there is a time to build a rapport before exploring feelings and about the pregnancy, giving clear and concise and accurate information and encouraging questions, trying not to make assumptions, and by using value neutral and unbiased language, conveying how common abortion is. Okay. Now this particular slide is going to be very important, and for this slide only I kept this presentation today. These particular values are frequently asked in one of the SVS. Okay, when you have medical abortion, they will ask you the continuation of the pregnancy rate is 1 to 2%, while in surgical abortion it is 1 in 1000. Okay, higher in pregnancies less than 7 weeks. So if the pregnancy is too early, if it is a 5.5 week pregnancy and you are doing it by surgical evacuation, the chance of continuation are high. Okay, so medical abortion has got 1 to 2% risk of continuation, while surgical abortion has got a 0.1 or 1 per 1000 risk of continuation. Okay, need for further intervention to complete the procedure. Now remember this particular risk because they ask these values in SBA. If you are terminating with medical methods below 14 weeks of gestation, it is 7% or 70 per 1000. Actually, I don't know why they have given different ways. They could have written it as a 7% and 13% here, but they have mentioned 70 per 1000. They have mentioned 13 in 100. Okay, so this become 13%. This becomes 7%. Below 14, 7. Just remember 7, 14, and 14. Okay, so below 14, 7%. Above 14, 14%. So near to around 13. Okay. So these patients will require a further intervention. Okay. while in surgical intervention below 14, it is around 3.5%. Okay, half of this, okay, in surgical intervention, or 35 per 1000, and above 14 it is 3%. Okay, infection rate is less than 1% in both. Okay, severe bleeding requiring transfusion less than 20 weeks, it is less than 1000. More than 20 weeks, it is 4 per 1000. It is very bit difficult to remember, but these values sometimes ask. Okay, so try to remember as much as possible. Okay, so severe bleeding requiring transfusion below 20 weeks, less than 1 per 1000. More than 20 weeks, 4 in 1000. Okay, here also same values for bleeding, values are same. Then cervical injury from dilatation evacuation in 1 in 100. Uterine perforation 1 to 4 per 1000. And uterine rupture in medical methods, especially in a previous scarred patient, around less than 1 in 1000. Okay, that too in a second trimester. So sometimes these values are asked. So you can make a note of this particular table. Okay. So pregnancy duration affects the choice of abortion method and setting, whether it is done in the home or clinic. It is usually assessed from the first day of the last menstrual period. LMP alone is often accurate enough for the most people, and routine ultrasound is not needed but useful if the pregnancy of duration is uncertain. Ectopic pregnancy is suspected if LMP is unreliable and ultrasound is unavailable. Use abdominal exam if pregnancy is more than 12 weeks, and perform bimanual examination if uncertainty remains and it may alter management. So primary ultrasound is not routinely indicated. So there are indications for the ultrasound. Okay. Then prophylactic antibiotics we have discussed last time. What they recommend is doxycycline 100 milligram for 3 days as per the NICE, and as per this SIP they have mentioned 100 milligram BD for 3 to 7 days. Okay, start within 2 hours of the procedure, and they have mentioned 3-day course is as effective as 7 days. Okay, then coming to the contraception, all these are UK MEC criteria, medical eligibility criteria, called as UK MEC, that is medical eligibility criteria. For first trimester abortion, all methods of contraception UK MEC are 1. Okay, for second trimester, except copper IUD and LNG IUD, rest all are UK MEC 1. Okay, so they may ask you this SBA, that following a second trimester abortion, the patient wishes to have LNG IUD inserted or copper IUD inserted. What is the UK MEC criteria? This number. So it is 2. UK MEC is 2. We will discuss all these UK MEC when we will discuss about the contraception. Okay, and after the sepsis, these copper IUDs, they are UK MEC 4. Okay, that means fully contraindicated. Okay, so that finishes our SIP on abortion care. Thank you. Okay,
Yes,
so we'll go ahead with the next best practice in abortion care. Actually, next are this is hardly 5 minutes discussion. Last time also I discussed, but the slides were not clear. That is why I'm going in details.